right. Hello. All right. I see everyone joining. Welcome to our session today. There are 54 people coming in the space. Really excited. I am Victoria Eckert. I go by she, her pronouns. I am the Associate Director at Youth Move National, and I am also a TA specialist with NTEC, the National Training and Technical Assistance Center. I am joining this space today as your moderator, and I'm so excited to have everyone with us. And we'll get started in just a couple of minutes. Love to introduce you to our team. And this is Elevating Family Voice through the Mobile Response and Stabilization Services Framework from Washington State. And we'd like to remind everyone of our commitment to maintaining a safe and accountable space today. If you experience issues and need assistance, please reach out to me by sending me a direct message found at the top right corner of the event. And to walk you through the tools in this session, I'd like to draw your attention to the vertical bar featuring several icons on the right side of your screen. If your event feed is open, it's going to be hiding your vertical bar. So please close your event feed by clicking on the X in the upper right-hand corner of the event feed box. Once you've closed your event feed, you'll be able to see a vertical bar with several icons. You'll see speech squares, that's the chat box for our session today. The Q&A icon, please use this to ask the presenters questions so they can keep track of all of the questions coming in. And you may also vote for questions if you're interested in hearing the answer to a question. Next, there's an icon of people indicating the participants in this session. And lastly, you'll see two papers stacked on top of one another. These are all of the resources from the presenters, including our slide deck for our session today. And to enable us to keep up with the questions, we ask that you please only use the Q&A icon and also take direction from our presenters as well. And at any time during the session, you need to step away, take a break, debrief, or decompress, please feel free to do so. Our wellness room is always open, and you may enter the wellness room by clicking on the wellness room button on the top left at the side of the event navigation bar. And a member of our team will meet you there. Okay, so now it is my pleasure to introduce our speakers for this session, and they would like to introduce themselves. So I'm going to welcome Sonia to the stage to get us going. Thanks, everyone.
Thank you so much for the lovely introduction, Victoria. And I am Sonia, and I would like to pass it off to Vashti to do our land acknowledgements.
Thank you, Sonia. Good morning. I would like to wish to acknowledge the traditional ancestral territories of the living indigenous people where we all live. We recognize that we are here because of the sacrifice forced upon the 29 federally recognized tribes in Washington State. Please join us in expressing our deepest respect and gratitude for all the generations of indigenous people for their enduring care and protection of these lands and waterways. We deeply honor and appreciate their historical connection to these places. I honor and thank the assessors and leaders who are stewards of these lands. I am especially grateful for receiving knowledge about the medicinal and healing properties of local plants, and I commit to caring for these lands and water and sharing harvests of healing plants with my neighbor. May we raise our hands for the diverse indigenous people in our lands today. Thank you.
Hello and welcome. We're going to begin now with our introductions. My name is Jasmine Martinez, and I come here with lived experience as a parent who has navigated the behavioral health system across 3 states. And it was in that navigation that I was brought to Washington, where I am now able to supervise one of our MRSS grant managers. And I come here today with passion for this work through being able to advocate with and for the 6 children in my home. Each child comes with their own beautiful strengths, gifts, quirks, challenges, and each one of those things make my world better every single day. And so with that, I'll pass it on to our next person who will introduce themselves, my team member. Thank you.
Jasmine. Hi, everyone. My name is Sherry Wiley, and I come to this work with my own lived experience of major depressive disorder since I was 17. I'm also a parent of a youth who received residential treatment, and I am a spouse of someone who was arrested during a crisis event when I was trying to get them help. And so I'm very passionate about this work because it's very near and dear to my heart. And I'm going to pass it to Vashti.
Oh, might help if I unmute. I am Vashti Langford, and I come to this work with personal lived experience, both family and family members, and along with the children I'm raising currently, but also in the professional role with working with youth for about 15 years and families, both in prevention and crisis situations. But it's really, I'm really passionate about it because raising my youth now, I've realized there's lack of support for youth in crisis and families that need it. And I will pass along to Sonia.
Hello, everyone. My name is Sonia. I use she, her pronouns, and I come to this work. I'm a person with lived experience, and I've been in behavioral health crisis myself, and I'm also a parent to two wonderful children, and one of my children has behavioral health needs, and I am learning and growing every single day. And so the MRSS work that we're doing together as a team is really meaningful to me because this is something I think when I was growing up that, there just wasn't any resources, not to mention hardly any knowledge about or open discussion around behavioral health issues. And it's just so rewarding and beautiful to see how open people are discussing this and building a system that is going to respond to children, youth, and families in a way that makes sense for them. And I'll pass it off to my colleague, Rochelle.
Hi, everybody. My name is Rochelle Madigan. I am a mom of 8 children, and because of that, I became kind of an accidental advocate. My family had a lot of difficulty accessing services and faced a lot of trauma in the effort of that happening. And because of that, I became kind of an accidental advocate, assisting other families in finding their way through crisis situations. And I am a grant project manager within this work, and very excited to share space with all of these wonderful people and with all of you, and to learn from one another. And I will pass it to Liz.
Hi, I'm Liz Venuto. I am also a mom of 8, with my oldest and youngest giving me some experience navigating the behavioral health system for substance use disorder and for something yet to be discovered that we're still trying to figure out how to explore and access for. I have the privilege of being able to supervise folks who are working on mobile response and stabilization and implementing it in Washington State, and getting to navigate the in-betweens of the systems. And so at this point, you have gotten to hear from our government employed state workers, who we affectionately know as our bureaucrats, and our family partners, our voices of, I'm sorry, I lost my spot, so we're just going to scroll for a second. Affectionately known as our bureaucrats, and our voices of lived experience from our statewide family network and our Center of Parent Excellence. As you can hopefully hear in our stories, our lives and our work are interconnected. And when we talked about doing our introductions with this group, we joked about playing a game, Name That Bureaucrat. So we wanted to invite you all into that. We like to have fun while we're doing the things that we're doing. So Sonia's going to activate a poll to see if you can guess that or those state workers. And there is a scroll bar, so don't think the top choices are the only choices. We don't want you to miss any potential bureaucrats while we play our game. But just we're hoping to engage a little bit and hopefully hear a little bit about the heart that we bring to this work and this space together. I think the thing I don't know is when we see the results. Oh, there we go. We've got a few front runners. Okay, we've got a good chunk of the voting in. I hope this was fun for some folks to participate in this game. For us and for our work, truly elevating family voice is not a checkbox. It's not just for feedback at critical points. It's really embedded throughout the development of and implementation of mobile response and stabilization services. So one of the next pictures you'll get to see is a little bit about how our work is interrelated and how we overlap. I am a supervisor at the Washington State Healthcare Authority. And so I have the joy of working both with my prenatal through 25 section, as well as our adult services section, which is where our crisis work lands. So we get to navigate at that level. I'll give folks a chance in a minute to say who they are in the organization they're attached to as well. But also just wanted to say one of the key components to this work, no person's role is more important than any others. We can all move and act different in different settings and spaces. We can say different things in different spaces because of the hats that we wear. And it's all integral to the work. Ultimately rolling out services that look like help to the communities in Washington. Like if we get it right, if we get that voice at the table, if we're really building in partnership, then what we produce is going to look like help to the community we're serving. And this team is really committed to showing up together and to allowing and inviting our humanness into the work, because this work requires trust and relationship and the ability to dive into hard conversations. So folks, just want to pop on real quick and just say your role at your agency. We can pull back the curtain.
So I'll start first for the HCA since I'm up there first. Vashti Langford, I am the Mobile Response Stabilization Services Family Coordinator. So my role is working with the family orgs, which are on here, and along with the partner agencies that are piloting MRSS currently in Washington State. We have one in Spokane and one in Pierce County, and helping build what the teams look like, working with trainings, and also getting the family organizations and youth voices in the right spaces to help form change.
And I can introduce myself and my role a little bit as well. So I work with Vashti and Liz at the Healthcare Authority, and I'm the System of Care Project Director, and we got the System of Care grant in 2022. And back in early 2022, Liz came to me and said, we were working on a previous System of Care grant, and Liz came and said, we want to focus on this mobile response and stabilization services. And she was extremely passionate about this as a potential way to shift our crisis systems to be more developmentally appropriate in meeting the needs of children, youth, and families. So she really pioneered the connections with some of the national technical assistance and like grounding us all in what is MRSS. So went and wrote the System of Care grant, and luckily we were awarded. And so this grant really focuses on 2 regions for direct services, and then also building the infrastructure, training, and all of the networking that we're doing to create a true system of care approach to MRSS in our state. And I will pass it off to Jasmine. Would you like to talk a little bit about your role? Oh, sorry, Sherry.
Sonia. My name is Sherry Wiley, and I am the Youth Mobile Crisis Team Administrator here at Healthcare Authority. And I come straight out of the field from delivering and supervising youth mobile crisis here in Washington State under this model. And I came up here to work on the 988 rollout. And so that's what we're working on, is ensuring best practices for youth and families occur in that space. And so our division partners very strongly with prenatal through 25 division to ensure that we're building programs that work for the people that utilize them, right? And so that's why we partner with our family-led orgs to design the rollout of MRSS. And now we'll pass to Jasmine.
Thank you, Sherry. Hello, everyone. Again, my name is Jasmine, and I do not work for Washington State Healthcare Authority, although I have to say that I feel as though we are colleagues. I feel as though we are partners and we are team members, but who I'm employed by is I am the assistant director of a Common Voice COPE project, Center of Parent Excellence. We are a family organization. And so I am blessed to be able to utilize my lived experience in navigating, as I mentioned before, crisis system and behavioral health, the most intensive inpatient and outpatient that the state and nation offers. And I'm able to support parents and caregivers in Washington utilizing that lived experience. And part of that role is to come alongside parents who are in despair, who feel as if they're in the middle of the ocean with crashing waves, just splashing them in the face, and they're trying to hold up their children in the midst of that crisis, in the midst of those waves, and then also advocate with team members through that desperation. And so what I love about this here is that partnership with the system and the healing that comes from that. And in addition to that role, I'm also the children's long-term inpatient family liaison. And blessed to be able to partner with all these team members here. Thank you so much. I'll pass it to Rochelle now.
Hi, everybody. My name is Rochelle Madigan, as I said, and I also am not a state employee. I work for another family-run organization called Washington State Community Connectors. We provide training and technical assistance to parents and caregivers who are navigating children's behavioral health services. I also do private consulting work as a parent with lived experience, assisting other parents in advocacy when their children's needs are not being met with resources at hand. I have been doing this work for quite a while. I did it for many years as a volunteer. And as I stated earlier in our vague introductions before we revealed who's the bureaucrat, my family faced a lot of difficulties getting help for our kids. One of our children utilized every service offered in our state, and it didn't meet their needs still. And in that process, I suffered a lot of trauma that was directly related to systems that were supposed to be serving me. So I came into this work having kind of an inherent anti-system bias, because I came to understand that systems weren't going to help me, and in fact, they might harm me. So being able to share space with these wonderful people and form this amazing partnership, it's really special. It has led to some really heartfelt collaboration. I think I can confidently speak for most of us on this call, probably all of us, when I say we care deeply about one another. This work is really important to us, and we share the space as partners in the work, and I'm really grateful to be a part of it.
So as you can hear from the stories and introductions, we come from very different spaces, experiences, and we sit at the table together through the things we all agree on, through the sticking points, trying to navigate. This is hard work. All of you who are in the behavioral health field know, all of you with lived experience know, it's hard work, and we don't come for the money, and the hours aren't always that 9 to 5, and then you walk away because you carry pieces of the work and the weight of what we're doing with you. So this is a fabulous team. We're going to talk a lot more about how we work together throughout the presentation today. This is a multifaceted, interconnected team. You'll see some of that throughout the presentation today, I hope. And with that, we'll transition to Sherry Wiley to talk about some of the technical implementation.
Thank you, Liz. So we're launching another poll for you today. What comes to mind when you think of a child, youth, or family in crisis? So you can vote on that poll. You can also feel free to share your thoughts about what a crisis is for a youth or families in chat. Maybe like, my child won't get off the couch, or my kid won't wake up and go to school. Something seems off. They're not eating, things like that. So just go ahead and vote on that poll, and then we'll give you the results a little later on in this presentation. Next slide, please. Next slide. Okay, so I'm going to be talking to you about mobile response and stabilization services. And for time, I'm going to use the acronym MRSS. So MRSS is the Youth Best Practice Crisis Model that recognizes the unique developmental needs of young people and their families. As Liz said, we are rolling out MRSS best practices here in Washington State through a System of Care grant, and we're in partnership with a Common Voice COPE project and Washington State Community Connectors, statewide family networks, and the Healthcare Authority. So next slide. All right, so here's a map of our state, the map slide. So Washington State contracts with 10 regions to provide crisis services. And we sent out some funding 2 years ago. I got up here to the state and I said, okay, where's the youth teams? And they said, oh, there's 4. I said, what? So we sent out some funding to make sure that all of our regions had youth teams. And lo and behold, in 2 years, now we have 14 youth teams across the state, and they're covering 18 counties and growing. So I'm going to speak a little bit about the crisis system. Historically, our crisis system is very adult-centric, right? So I mentioned, you know, my loved one becoming arrested when they were in crisis, and that's because the adult model is based on more restrictive processes. So it's an acute presentation that's required. So I had to wait for my loved one to get to the point where I knew that they could be legally admitted to the hospital. And so that resulted in contact with law enforcement and arrest. So we don't want kids to get to the point that adults have to get help, right? And so the adult system, because we wait on the presentation to become acute, that does cause a lot of severe mental health, concerns. And we also have acute presentations that require law enforcement response, and symptoms can appear non-compliant, right? And then we know that arrests delay treatment. They delay that definitive treatment. And so young people are not small adults. They're developing humans. They're system involved. And while they can benefit from talk, text, and chat, the reality is that it's the adults in their lives and the systems that touch them that are going to notice a shift first. And they're going to be the primary people calling the crisis system to get that young person some help. So schools, primary care providers, existing behavioral health clinicians, they all send kids to the emergency room. I mean, that's what we were trained in our master's level programs, right? Suicide, emergency room. This is neither trauma-informed nor developmentally appropriate. Parents and caregivers don't necessarily have the words to describe a crisis, and we don't want kids to rise to adult definitions of a crisis before we intervene. If a parent calls 911, again, that means they're going to get transported to the emergency department, or worse, they could have juvenile justice or family court involvement. This slide shows the adult model and the youth model. So the adult crisis model is someone to call, someone to come, somewhere to go. For youth, we're not going to pick them up and transport them anywhere. So the somewhere to go means a safe place to be or a safe place for help. We want kids to stay in the home, sleep in their beds, and attend school, all while staying safe and supported by an MRSS team whenever we can. If that team and that family feel like they need more support or facility-based care, the teams can level that up and support the family to do so. But by implementing a system that responds when people ask for help, we can ensure that there's space in those facilities and beds available for those kids who most need it. The adult model, that Crisis Now calculator, is based on about a 20% in-person response rate. And with youth, we want the inverse. We want an 80% in-person response rate. Our teams in the state now are meeting that metric. We did have a study done by one of our emergency departments here in Washington State. And they found that for youth that went to the emergency department for behavioral health needs that year, 61% of families reported negative functional impacts. And that was associated with long lengths of stay at the emergency department, not knowing what they were going to do for this youth, right? They're stuck in medical clearance. 33% of the youth reported that the visit was not necessary or made things worse. And the study concluded that the top possible diversion to ending up in the emergency department in the first place was mobile crisis outreach teams at 98%. So we want to shift from a risk-averse medical model that requires evaluation and treatment in the emergency room for kids with behavioral health needs to understanding and believing that we can keep most kids safe at home, even with some level of risk. Next slide. So MRSS is an upstream intervention. When a parent calls a crisis line, we want to believe them and go. When a school calls a crisis line, we want to go. We want to get eyes on that youth. You know, a school counselor might be alerted that a youth is Googling something online, right? Maybe how ways I could hurt myself or something that's triggered an alert at the school. Is it really appropriate to send that kid straight to the emergency department? Or is it more appropriate to get a team in there and they can sit with that kid and say, hey, you know, what's going on? You know, I understand, you know, you're Googling some things and we want to work with you and learn more about that. Let's get a really good understanding of what's going on before we start sending kids just to the emergency room. So MRSS has two phases, right? It's going to meet a sense of urgency with urgency, and teams are going to respond with a clinician and a parent or youth peer. That's going to provide the most appropriate engagement, de-escalation. The teams are going to do safety planning. And there'll be peer support for the parent or the youth, depending on if it's a parent or youth peer, and also depending kind of on the age of the youth. We believe that peers are critical to the success of MRSS. I'm a parent. When your kid's in crisis, that's not water cooler chat around the office. It's not something you're going to Teams chat your colleagues at work. But a peer is going to sit on the floor with you while you cry because they've lived it. They know what you're going through, and they're going to offer you that hope. So the clinician is going to work with the youth to really understand what the strengths are and the needs are and what the risk really is. Based on that risk assessment, they're going to, they're going to sit with that kid and go, what's going on? You know, can you tell me, you know, what this looks like? You know, when you want to hurt yourself, what's the frequency? When does it happen? What's the intensity? You know, do you have a plan? And based on that really good eyes on risk assessment of that youth, the team's going to support that caregiver to feel confident keeping that youth safe at home, because the team's available to respond 24/7 if there's anything that escalates. The other thing they can do is help support that caregiver to secure lethal things in the home, right? We want to get the medications, we want to get sharps, maybe just whatever the clinician identifies that could be something that the youth could harm themselves with. These brains are developing, kids are impulsive, we're just going to slow them down, right? And so if the family agrees, the team can follow up for the next 3 days with that family, and that's our crisis intervention phase. And if there's more time needed to work with that family and make sure that they're supported and they're not going to go back into crisis, there's an additional stabilization phase for up to 8 weeks. And that's going to give the team more time to ensure that family has the necessary supports in place. So during that phase, there's peer support, skill building, psychoeducation, and really working with that family to understand what interests the youth has, and then connecting them with all the natural supports in the community through wraparound principles. The teams also maintain partnerships with all system of care partners so they know where these hyperlocal resources are. Next slide, please. All right, so MRSS is going to improve outcomes. Why? Because young people can get help before rising to the level of how we define a crisis for adults. This is often the first contact that a family is going to have with the behavioral health system, especially youth. And so teams should build a trusting relationship with both. So this can change the trajectory of a young person's life, right? Our 14-year-olds are going to make 18 in 4 years. So if they're juvenile and justice involved now, if they're having early behavioral health symptoms now and we don't intervene, they're going to be 18 in 4 years and they're going to age into the adult system, possibly justice system involved, possibly not have graduated, possibly homeless. And so these investments are going to reduce reliance on the crisis system and the adult crisis system in their life. And these young people who have a good experience with a behavioral health intervention that really centers family voice and choice, it's going to increase the likelihood that that young person will seek treatment in their lifetime. The MRSS teams provide warm handoffs to the clinical supports in that community so that we get the right intervention delivered at the right time and the right intensity. This prevents return to the crisis phase. We want to put the teams want to put themselves, out of work, right? We want to make sure that families aren't coming back. If families are calling a crisis line over and over and they're not necessarily getting their needs met. So a successful MRSS intervention is that the family and youth get their needs met, they're connected downstream, and they have the tools in case another crisis occurs. And they can trust that you're going to show up when they call you back. Next slide, please. Oh, so remember that poll you took? All of those scenarios are something MRSS can address. If a parent can't work because they're picking their kid up early from school or daycare, that parent is in crisis. School refusal is a crisis. The team can get an appointment the next day with the school and the youth and the parent and put some supports in place. They can safety plan at school. Something seems off during a crisis and parents know their kids. So when they call, we need to trust them and go. So I'm curious how you all would define a crisis. I'd love to hear more of your thoughts in chat or additional scenarios, and we can answer more questions during the Q&A. I want to highlight that one there in quotes. I can't get my child up to go to school. I was supervising a clinician that day who was not very happy with that call. They wanted to come to crisis staffing because that's, something interesting we do once a week. And I said, go on, get out there, get eyes on, let's see what we've got. And they said, this call turned out, this kid was unconscious, unresponsive. So we had to go ahead and activate EMS. The kid is fine, but the moral of the story is you don't know what you've got till you get out there. So you need to get out there and get eyes on the youth. And I am going to pass to Sonia for our next slide.
Thank you, Sherry. I would like to direct the audience's attention to another poll, and I'm going to show it on stage. And I'm just curious, how many here know what the system of care values are? So go ahead and put your votes in, and I'll be interested to see what you all think. I've worked on, this is the second system of care grant project that I've worked on. And something I've noticed is that people who are deeply involved with any sort of system of care project are probably familiar with what system of care values are, but there are a lot of people that may not be, or they've heard of it once or twice, but they haven't really seen it work and live in their day-to-day work. So just to review, the system of care values are family and youth driven, community-based, and culturally and linguistically appropriate services. And I think something that's really beautiful about the system of care values is that they're simple. There are 3 of them. They're easy to remember, and yet they're so expansive and encompass so many different facets and can be really woven into every single thing that we do together as a team, and the way we think about our work, the way we think about our relationship to our role and to each other. And so I'm working for the state. I'm working on a system of care grant that has really specific goals and objectives, some of which, we have to meet criteria for SAMHSA with data collection. But it's really thinking about how are we going to drive everything from the basis of these values and hold ourselves accountable to those values. And so I, as a system partner, am thinking about, well, when we develop the services, when we talk about what's going to go into the contract language, how are we going to monitor this? How are we going to ensure that there's proper opportunities for feedback, advocacy, sharing ideas, and also how are we going to ensure that we're reaching and being intentional about how we're reaching communities that have historically been marginalized and do not maybe historically feel comfortable reaching out for help when they need it. And there's a long ways to go, and there's a lot of work to do in that area. And I would like to invite Jasmine and Rochelle to also share on their perspective about what do the system of care values mean to them coming from the family organization lens.
Thank you so much, Sonia. You know, I think when it comes to the system of care values and what they mean to me as a parent is that our fingerprints are on the plan. It's not a matter of, it's even going beyond family and youth driven, but family and youth authored and co-authored with the team that we are working with. It's often said and heard that parents and caregivers are the expert of the teams of their family, right? And I do believe that. And I believe that my son and my daughters are also experts. So we are an expert on this team. And if we are navigating the crisis system, we are in need of other experts. So that collaborative work, and when system of care values are woven in, that makes a difference in terms of impact and how these interventions truly roll out.
Yeah, I would agree and second everything Jasmine said. And I would add, I think it's really impactful that the community-based and family and youth-driven elements, and as Jasmine said, family and youth authored, that makes all the difference. When you've experienced trauma due to people not believing you, due to people not valuing your knowledge of your child, it causes harm. And so having that as a core foundational element of this work is really amazing. I wish I would have had that when we were experiencing the difficulties we were experiencing. And so to be able to be a part of this work is really meaningful. Again, it has taken, you know, I like to talk about how we're all shared humans before we're everything else. And arriving at this place of being able to be in this beautiful collaboration with people that you've just been introduced to, it's been a growth process for me because I again came into it with very thick trauma goggles. And it's really meaningful. It's meaningful to not be, you know, I feel like having done advocacy for a long time, there are situations, maybe some of you can identify with this, where you get invited to participate in something, but you can feel that you're being tokenized. You feel that you got invited so someone could check a box somewhere. And that is not this. This has been absolutely the people, the bureaucrats that you've been introduced to are some of the kindest, most caring humans. And we share space together, and we're building, we like to say we're building the airplane while we're flying it, because we're still implementing MRSS in Washington. And that has some inherent bumpy places. And because we're shared humans in the work, we can navigate those bumpy places with grace and with care for one another. And so again, I'm just really grateful.
Thank you for sharing that, Rochelle. And I think we view the system of care values, if that is going to ground us in how we're going to approach things, and we're seeing MRSS as a way to operationalize and bring these values into the system and the continuum of care that we have in our state. And some of the points that Sherry had touched on, you know, family and youth defining the crisis, parent-led organizations as partners with providers and systems, incorporating youth and parent partners and peers into the work from the initial crisis response through stabilization and the network and community engagement. And then also having youth and families give input and help develop quality improvement efforts. And I would like to transition into how system of care feeds into MRSS core principles and pass it to Jasmine.
Thank you. You know, I do want to add in addition to that, that it does take courage for any agency to welcome family and youth voice while it's still gray and bumpy, and welcoming that feedback before it's built. There's something to say about that integrity that I think is worth echoing here. That's a huge takeaway, that we're invited in while it's still gray and bumpy, and that we are building this together, and they're truly hearing from youth, parents, and caregivers as we're building this. And so that right there is the heart of system of care values. And with MRSS, system of care values, the goal is that those are infused in every single one of the core principles. And if the system of care values are not infused and embedded in each one of these core principles, then these core principles are just nice circles with words. Nice circle with words. And we want to move beyond just trendy, popular words that need to be said. With MRSS and Washington State Healthcare Authority and the Family Origin, this partnership, it's that the system of care values bring these core principles to life. And as a parent who has navigated the crisis system across 3 states, as I've mentioned, and now as a professional who's supporting parents and caregivers, the system of care values being embedded in each part and seeing that, seeing the difference it makes for parent and caregiver wellness as they are advocating and as they are navigating the system, to hear Sherry say words like, "We believe you. You call, we believe you, we come." That alone changes the system. It changes the system for a parent to feel believed. And so right there, I'm going to touch on safety. You know, I have a son who lives with every form of psychosis possible since he was 5 years old. And when it comes to psychosis and delusions, it's common that if they feel as if those delusions are being come against, then they will do everything they can to protect that delusion. And so my son was able to maintain, and many times I was told, oh, he couldn't possibly maintain. He's too young for sophistication of that level. And here I was fighting for my son's life, fighting for the safety of the community, fighting for my family. And had I had the system of care values embedded in the support we were receiving, I would have been believed. My son would have been believed, because guess what? My son is a safe, loving, kind, brave, bright human being who happens to live with psychosis. He has psychosis. Psychosis does not have him. It's not his definition. And when it comes to system of care values, that also does a number for my son's wellness, as he also is advocating as well. And so when it comes to the system of care values being woven into each part of these, it changes the game. And I would love to hear what Rochelle would have to say about that as well.
I actually don't have a lot to add. I just would say, specifically around a couple of these circles, the trauma-informed, equity, culturally appropriate, all of those things, if we aren't intentional in connecting with families who are utilizing services we're providing, we aren't going to be able to get that. I always talk in every space about qualitative data, about hearing how things are going from people. And having those underlying foundational system of care values of valuing and incorporating those voices makes all the difference, because you won't get answers to questions that you don't ask, and you can't ask questions if you don't get around people who have the answers you're looking for. So it's really important to authentically involve families in this work, and system of care values are the foundational way that that's happening. And it's really exciting to me as a person who suffered a lot from not having that.
So now let's ask a couple questions. How often do family organization system partners share the same space? You can drop some things in the chat. And also, how do we move our process in the direction of these shared values? I come from a world of, I love input. I love learning from people. I can create whatever, but if it's not working for everyone, am I doing it? Is it effective? I think it's very important for partnerships to help develop, especially something, this is like Jasmine said earlier, this is a very gray area. It's bumpy, it's rough. Our cohort loves to say, building a plane while it's flying. Very true. But I've been on the outside as a parent needing assistance for my youth, my family members, and not being heard, not being listened to. So I've also worked with families that and youth who have felt not being heard, not listened to. You'll get over it, or they'll get better. And it's really imperative for me now, coming on the inside of the system, to get the same input from families who have been through it or currently going through it as well, alongside of me. It's very natural relationship. I believe Rochelle said earlier that we are just very naturally connected because we have similar situations that we're currently still going through or have gone through in the past. Next slide. So the system's changed by building relationships and keeping those relationships. The community, you hear people talk about all the time how we work from within the community, but if you're working within the community and it's not working for that community, are you working with the community to make sure the community's getting heard and listened to and getting what they need? Communities help identify what needs need to be met. My job as a system partner is to ensure that what I want them being heard, but they're seeing results of what they're saying to us. They're seeing results of what has been promised to them. We don't want to promise anything. What we want to do is help build something that's going to be effective, that's going to work for everybody, that's going to challenge the system. I mean, that's the only way things change, is if we have the right people in the right positions to challenge the system. And sometimes people working with us in the system kind of forget what it looks like on the outside. And our relationship with our family orgs and partner agencies show that there's change to be had, but sometimes the providers don't realize that because they're in their silos. But when they're able to be in the same room with family orgs that are currently experiencing what they're serving, they're able to get that information that they need in the correct spaces. Next slide. So another question: how do we navigate policy and infrastructure development in true partnership with families while in the midst of implementing something complex like MRSS? Feel free to drop some answers in there. It coming into this work, again, from working on the outside of the system, inside the system, under a year, has been really eye-opening, and it helps me understand little things from the outside that I dealt with. But it's got to be about the family. The family defines a crisis. The youth defines a crisis. No one in their right mind can tell me what I'm experiencing when my child is getting violent. No one's going to tell me that she's upset because I told her no. No one's going to tell me how I should feel. And no one's going to they shouldn't tell another parent that. Parents need to be listened to. Family and youth need to be heard because they know how they're feeling too. And if they're making that phone call to a crisis center, they need to be able to have someone firsthand coming out and talking with them. Family voice, yes, I love that. Yeah, no one is too young for crisis. No, I totally agree.
Vashti, I wanted to chime in really quick because this is an important thing to highlight, I think, as we were talking about some of the benefits of the partnership between systems and family orgs. Another one that I think sometimes gets missed in conversations is bureaucrats, although we all share lived experience and many times have similar life experiences contributing to why we do this work, bureaucrats often have agency limitations around what they can say and what they can share, and around being able to move legislation and sometimes to break down barriers that exist in policies. And fortunately, family orgs they're not bound by those same barriers. So partnering between systems and families can be really beneficial for breaking down barriers when there are infrastructure things that are in the way, or policies or additional funding that's needed for stuff. Being able to amplify family voices through collaborations with family orgs can be a really powerful tool toward achieving those things. Just wanted to highlight that.
Thank you, Rochelle. We are going to pass it on to Liz.
And Liz is going to go rogue. So there are two things.
Figured.
There's a choose your own adventure pathway. So there is a poll that's going to be active. We had some questions we brought that folks can vote on to see what they might want us to talk about. But with the time that we have left, we see there are a whole bunch of questions in the Q&A. So we're going to take a little time and answer those. Feel free to, if the poll is up, feel free to vote on the poll while we go. And we're going to start out with, in Washington, how is mobile response and stabilization services funded? Does the family have to be on Medicaid? And I'm going to pass that one to Sherry.
Yeah, that's a great question. So for MRSS, the first 72 hours is funded through Medicaid and general state funds. So that's an entitlement for everyone in the state. The stabilization phase is funded by Medicaid, and we did have a bill pass a couple years ago, the Balanced Billing Act, that requires commercial carriers to pay their fair share for emergency services as if the person was in network. And that we're working with the Office of Insurance Commissioner to iron out how to stabilize the commercially insured kids. Our System of Care grant is stabilizing those kids in 2 counties, and we just had some funding approved by our governor to extend some FTEs to all these teams so that we can cover those commercially insured kids. And that sort of leads into the next question. So this next question was, what happens when the MRSS feels there is a need for further intervention and there are few, if any, mental health providers in the area? This does happen. And so when the teams, for one, MRSS can be in place for up to 8 weeks. And I'm going to tell you the clinical markers are going to really start to go down. And as that family's connected and supported and the youth is connected and they're doing things that make them feel successful and they're in their bodies, you're going to see a shift. So they may or may not need that extra clinical component. If the teams do think that the youth can't be safe at home, they will absolutely work with our responders in our state that can help facilitate an inpatient stay for a minute. Sometimes that's the key. And then the MRSS teams can support them on the discharge day. They can come to the home and help the parent keep that kid safe at home. And your commercially insured kids are, because there's a few providers for those kids, in my experience, those commercially insured kids often are best connected back to the school behavioral health system because they're already in school and those providers are happy to check in with them and keep eyes on and let the teams know if there's some more safety concerns or needs for the family. And I'm going to pass to, Liz, you want to do another one or do you want me to do the unthinkable?
So just touching on that, because it did talk about what if there are no providers, the workforce strategies used to ensure 24/7, 365 days a year services, especially when dispatch percentage expectation is 80%. What are our strategies? And so we're doing, like, it's incremental. We're not getting to 24/7 in all regions all at once. We're building and trying to be responsive to capacity. And also, we did a state plan amendment in Washington state to allow peers to be able to respond in crisis situations along with our mental health provider. And there are specific behavioral health crisis trainings for peers so that we can make sure we're not just shifting folks into that position without preparation and support. So those are two ways that we're working on increasing the workforce around this. And I think some work still to be done is for mobile response and stabilization. It's different than someone who might go through a clinical program to be an outpatient provider. It really is first responder oriented. And so there's some education, the cross education that needs to be done so we can get the right folks interested in and engaged in this type of mobile response. All right, I'll pass it back to you, Sherry.
There's a question about if the unthinkable happens and a family loses a loved one. I've seen many kids referred for this, even either the parent, something happens with the parent, or maybe there's an incident at the school. The teams can go in and let the school know they're there. We don't want the school, dealing with that on their own. We want to make sure they know how to access the teams. All right, and then as far as for a center to go to, we did pass a bill this year for youth 23-hour crisis receiving centers. Remember, again, we don't want these to become feeders back into that medical facility-based care. Our MRSS teams can go and help support safe discharge from those for the majority of kids.
All right, and so I'll put out to the room. I see another question about in lieu of services in there. We're going to have our contact information in the chat. I think there are some of these that if we don't get to them, we can reach out to you and try to provide more specific answers. I would like to let you know. Okay, so has this poll run? I can't see the answer yet in my response. If it has, I think we'll just close out by responding to the question that folks voted on that they'd most like to hear some response to, if that works for the team.
I'm seeing the one with the most votes as how do you approach quality improvement and data collection in partnership with families? What is working and what is not?
I just want to step back and give Rochelle the floor.
That's so funny because I was like, oh, I need to talk about something on this one. So recently in a conference that we were at, Jasmine said that she has word pictures when she thinks of people. And when she thinks of me, the words qualitative data come into her mind. And that's because everyone who will listen to me, I say, we've got to stop basing all of our data collection on only caring about numbers. People aren't numbers. And when we only care about numbers and not stories, we miss the folks that weren't well enough to fill out a survey because our systems failed them. And so qualitative data is something that's really important to me. For those of you that don't know, qualitative and quantitative, when you look at those root words, it's quality and quantity. So quantitative data looks at numbers. Qualitative data looks at how things are going. And how you know how things are going is you ask the people that are utilizing those services. And people who have ended up homeless or stuck in hospital beds or had horrible life outcomes often aren't going to be available to fill out your survey that cares about numbers. So in Washington, we have been really trying hard to find pathways that we can gather qualitative data. We're not there yet. It's another airplane that we're flying while we're building it. But we are really trying hard to come up with ways that we can collect qualitative data. We have what's called FISPERTs in Washington, which are Family Youth System Partner Roundtables. Yes, FISPERT, which are collections of family members within communities that have lived experience that elevate their voices to inform systems. We have many work groups that are working on various things regarding children's and family mental health, behavioral health, which encompasses mental health, substance use, problem gambling, and other things. And we invite family members to participate in these work groups. So again, we're not there yet. I feel like we probably don't have all the answers on what the right approach is, but from a family member having experienced some terrible outcomes, I can say the fact that we have families embedded in this work bringing forward things like, hey, you need to care about family stories. That is going to make the difference in how our systems look moving forward as we're re-envisioning them. And I'm excited about that.
And I would like to just chime in and build off what Rochelle is saying, because she's really opened our eyes in terms of how we're looking at MRSS and our system. And I feel like the systems, the data that our state and that probably other states and federal partners look at are really tied to, like Rochelle was mentioning, the outcomes. So what is incentivized is to look at the data on where people actually access services, that know the services existed and received some type of services and potentially had a somewhat positive outcome that they're feeling willing to participate in that data collection. And that probably applies to a really small subsegment of people that need behavioral health or would benefit from behavioral health services. So the data collection incentivizes ignoring where things are not working. Pardon me, my phone is.
With that, we see that there's 1 minute left and we're getting ready to transition on to the next so you can continue to enjoy this really rich and robust conference. Our contact information is on the last slide. If you've got additional questions or want more information about what's going on in Washington, we would love and encourage the reach out. Thank you. This is just an amazing team to work with. I appreciate all the effort that was brought to the table and all of the sharing and humanness that is even a part of these presentations. So thank you all, and I hope you enjoy the rest of your conference.